Thank you very much. As you've had a bit of introduction about bicuspid valve, I may be able to skip over the odd thing. So I'm a congenital and structural cardiologist. I'm multiply conflicted, which probably means I'm balanced about different companies. I probably won't say much about this other than to say assessing bicuspid valve, the severity of disease can be difficult. So saying what's moderate and what's severe, I think, isn't always as straightforward as you might think. There's a nice summary there. In the interest of time, I won't give you time to read it, but it's one of the references I give you. You can see it. And it basically says that these bicuspid valve patients weren't in all the trials, so we haven't really got the same head-to-head data that we need. I'll gloss over this because we've covered it. And there are a couple of papers. Again, in the interest of time, if you want to look at these are useful papers that give you some follow-up data. So this is just a summary from one of those papers. If you do TAVI in a bicuspid valve, they're not the patients we've just heard about in the last talk, mind you. These are generally older patients. They have a reasonably acceptable 30-day mortality for a high-risk population. Their one-year mortality is pretty good. Stroke happens, unfortunately, in TAVI as it does in surgery. Probably the big difference between TAVI and surgery for me is actually pacemaker implantation. And the younger the patient, the more adverse an outcome a pacemaker is, really. So I think pacemaker is the thing to think about when you're deciding between surgery and, or one of the important things to think about deciding between surgery and TAVI. Moderate or severe paravalvular leak isn't as common as I think some of our surgeons like to think it might be, but I'm going to come on to that in some detail. Vascular complications are actually low in bicuspid patients because they don't have so much coronary disease as patients with trileaflet valves, so the vascular complication rate is lower than in trileaflet, and device failure is pretty rare. This is a comparison between balloon expandable and self-expanding. The things to focus on are the self-expanding valves have a slightly higher pacemaker rate, but balloon expandable valves are not without pacemaker rate, as some people I think consider. And otherwise, there's not a great deal to choose between them. The big clinical thing for me is that balloon expandable valves rupture the annulus sometimes. And if that's a low-risk patient and the annular rupture rate's under 1%, I can tolerate it. But in a high-risk patient, if it's a 4% annular rupture rate, I can't really tolerate that. So I think that's the argument in favor of self-expanding valves. And some of these bicuspid valve patients are complex and have funny left ventricular outflow tracts as well. So this is just a direct comparison of trileaflet aortic valves with bicuspid valves that we would consider reasonable candidates for TAVI. So they're type 0 and 1 without a horribly calcified raphe. And actually they do pretty almost indistinguishable. So TAVI as a technique for the right sort of bicuspid valve does seem to be entirely reasonable. Just another thing about the different valves involved, and in the interests of time, I'll probably jump over this because I don't think it's that exciting. This is the study that had that nice paragraph that I thought was useful. And this was a group of patients with a mean age of 75 with high comorbidity. And that's their long-term, relatively long-term outcome. It's not the same as long-term for congenital patients. But this isn't a procedure that just suddenly has an inflection point. The inflection point at the end is based on such a small number of patients, it's not relevant really. So this can give a reasonable prognosis after treatment. And this is a bit about durability of the result. Even in a bicuspid group, you can take the initial gradient that was pretty high down to a pretty acceptable level, which is very comparative with surgical valves. I think sometimes some surgical valves have higher gradients than TAVI valves, and maybe one of the advantages of TAVI is in terms of effective orifice area after intervention. but I think surgical procedures can sometimes improve that. So it's, again, a balance. These valves don't fall apart. They don't suddenly start leaking after a few years. You get a reasonably durable result, at least up to 4 years. And there's some very nice data from Medtronic showing actually at 7 years, the Evolute valve actually slightly outperforms the surgical valve that they chose to compare it with, which might not be the surgical valve I would have wanted them to compare it with, but the data is there that Evolute valves outperform at least one of the surgical valves at 7 years. I think this is a really important slide. So this is showing you that the nasty outcome one, the blue one, is in the patients who have a calcified raphe, which stops the valve expanding. I'll show you an example in a minute, and excess leaflet calcification. Whereas the patients who don't have any high-risk features for a bad result from TAVI get a pretty good follow-up, and the ones with a calcified raphe or excess leaflet calcification get a reasonable one. It's when you combine the raphe and the leaflets being horrible that you get a problem. Again, another nice paper to have a look at, and it's really for the picture on the right I'm showing this. You can see there's a mass of calcification, and then you can see on the right panel, the right two pictures, there's a transverse view of a self-expanding valve. It's a Medtronic, I think. It's oval, but the inflow is oval, so that doesn't matter too much because the inflow of a Medtronic is designed to be deformed and doesn't actually hold the valve. So the valve sits somewhat higher in the frame. So the valve isn't actually so deformed. This is one of the reasons I like to use Evolute valves in bicuspid, because the oval and distorted annulus doesn't actually affect valve function because the valve sits above it. And the bit of the frame that contains the valve has something called hoop strength, which means it goes round as best it can, and unless it's constrained from doing so. And if you plant it above the calcium, it's not constrained, so it does what it's meant to do. So I think that's important, but it also exemplifies the horrible distortion you can get from calcification in these valves. This is a very nice paper. Didier Cheche from Toulouse was the lead author on this. And you probably want to read this if you're really interested in bicuspid valves, but they talked about the importance of classifying the valve and really understanding the morphology of it. And if we're going to put a prosthesis in, we have to understand what the prosthesis is going into. You guys get to have a look at this. You can open the patient up and have a good look and see what's going on. We have to look in advance and measure up in advance. And this is explaining how you may have to differ your approach to measurements by imagining how the prosthesis is going to fit into the anatomy. If you don't understand the anatomy properly, you're not going to choose the right prosthesis. And you can do that by looking at it. We have to look at it in advance. And I think this is a really nice paper that most implanting cardiologists would regard as being the best paper in this area now. So can we predict who's going to do well? Yes, I think we probably can. We need to look at the CT and echo morphology and the calcium and all of those things on the side there. I've not talked about the ascending aorta, but if you're doing a TAVI and you've got a horrible big dilated ascending aorta, it makes the procedure much harder to get things in the right place and properly aligned. But we can also use, we use experience to know what a valve's going to look like, and you put it into a certain morphology. But this is essentially AI, which has looked at outcomes and is able to model the position. So Medtronic support this, and you can see a Medtronic valve put in there, see how it's going to expand. Here's another example, putting in a bit deeper or a bit shallower. You can get to see what goes on. And here you can see that the inflow is deformed on that bottom left panel. And you can see the CT on the right. So this takes the prediction of outcome to another level. On the bottom, on the middle two pictures of the implant position, you can see one is more of a frontal position and the other is from the side, and you can see how it's constrained in one diameter but not in the other. And this helps us to predict those that we're not quite sure about whether we're going to get a good result. No, it's not going forward. There we go. They can also look at the pressure of the frame on the anatomy and also predict how the skirt will sit against the anatomy and whether there'll be a paravalvular leak and whether you should implant high, low, or in an intermediate position. So this is taking that prediction of outcome to another level. And I think we do need to probably do more of this and not just rely on our experience. So we've heard about lifetime management already. So this is entirely my own view. It doesn't come from any guidelines. So I think if you've got another reason to do surgery, then you're just going to do surgery. If you've got an undilatable raphe, then you're probably better to do surgery. And bicuspid valve patients have a slightly abnormal mitral valve sometimes. The anterior leaflet can often be long with a rather small posterior leaflet. And we've got a few patients where our surgeons have actually done an Alfieri in that situation, and it seems to get different results from a normal Alfieri. So I think about the mitral valve as well. If you've got a small annulus, then we can get a reasonable result in an okay annulus. But if you've got a small annulus, then maybe you're better to do something to make it bigger. And I work in a congenital center, so we actually use a Ross for young patients because that really makes it bigger. We do need to think about long-term results, as has been mentioned already, and a mechanical valve isn't a bad option, but I think particularly the German registry shows that actually the outcomes aren't as good as you hope or think they are. If you've had endocarditis, probably do surgery. And I think pacing risk is really important to think about. And the radiologist can give us an idea about that by measuring the septal, the height, the septal height. They can sometimes predict that, and you can always look at the ECG, and if it's right bundle, then you're much more likely to need a pacemaker. So for the TAVI ones, surgical risk, all of those reasons I've put, and I think sometimes if your aorta's not quite big enough to need changing yet, and putting in a TAVI that's just in the valve, and then if that lasts 10 years, the aorta might need doing then, so maybe you don't need to replace the aorta when it didn't have a true indication. And delaying the first stenotomy is really important. I've got patients I've done a TAVI on, and then they've gone and had bypass surgery 5 years later as a first-time stenotomy, and they didn't have nice coronary disease for stenting. And I think some of the patients need a bespoke solution. Here's one of those that needed a bespoke solution. He turned up in cardiogenic shock. One of our surgeons said, "I'll kill him if I operate." I don't know whether I suspect many of you would say, "Oh, we'd have just operated." But he came to the cath lab with not very much in the way of ventricular function. We didn't even want to anesthetize him. Hopefully that middle one is a valvoplasty that's just about to happen. Did a valvoplasty. Then we put a valve in and it just didn't expand. And if you look at the bottom right panel, didn't expand. But we were committed by this time, and the outcomes of these procedures depend on where you start. And I declined to do this patient, but he came back to us. Maybe I need to press the button again. So we didn't get a proper expansion because of the ugly annulus, but we did get better expansion with a strong balloon, and actually eventually got a reasonable result. That little bit of regurg you can see isn't it settled down and really wasn't very much. And then 6 months later, his ventricle had perked up somewhat. So that was a patient that you would have said was a complete no-no for TAVI, but we got a result, and this was done in 2021. He hasn't come back yet, but will, I'm sure. Just a few odd cases. Here's a Fontan. This is a bicuspid valve. And she was 53 at the time of the procedure. And we put a TAVI in this. This was I think it's the first one in the literature. And these patients are going to have bicuspid valve. They have bicuspid valve disease because they're congenital. And sometimes you need a bespoke solution. And this was her bespoke solution. She's in heart failure now, 5 years later. We did that in 2018. But she was turned down by our surgeons. Here's another elderly man with a bicuspid valve and a prior coarctation. And you can see his valve's horribly eccentric. And he was turned down by our surgeons, so we did a TAVI in him. And you can see here, this, I think I've shown this because it's such a nice example of how weird the root can be sometimes, where you've seen the left positioned sinus is much higher than the right positioned sinus. And he had a bit of paravalvular leak, but lived for a number of years, probably 5 or 6 years he lived for this, and died of something else in the end. This is just to say that surgical valves sometimes have paravalvular leaks too. So this was a patient after a surgical tissue valve. But luckily we can do something about that. This was a mechanical valve, rather than the tissue valve. So he had a leak under the left coronary sinus. It's quite difficult to get across, so I had to cross it and then snare the wire to help me across with a sheath. I think I might have to keep pressing the button here. And then we put in a paravalvular leak closure device, which essentially got rid of the leak for him. And just as an aside, you see the picture at the top right. Whenever you're doing these procedures, you need to get the right view to show the leaflets moving fully. And it's actually very hard to do that because there are only 2 views that show it, and they're 180 degrees apart. We can do some paravalvular leak closure in TAVI, but it's usually they need to be dilated more. And hopefully I've caught up a few minutes. Thank you.